Could be Chainuvati. This is this could be the only named lecture for the meeting 2016 Chainuvati Lectures to honor Professor Tamchai Chainuvati for what we have done to the contribution to the liver disease in Thailand. Professor Tamchai Chainuvati graduated from Sirat Medical School and then he went to United States to complete his fellowship, his internal medicine and fellowship in gastroenterology in New York, United States, and also the fellowship in hepatology in Boston with Professor Hyman Zimmerman and at Yale University with Professor Kaskind. Locally in Thailand, he has been the president of Gastroenterological Association of Thailand 2 terms from 1986 and 1990, and chaired the liver sections of Gastroenterological Association of Thailand from 1994 to 2000. And during that period, he has initiated the Liver Cup of Thailand from 1996 and then become the Thai Association for the Study of Liver nowadays. Also, he was the president of Royal College of Physicians of Thailand from 2004 to 2005. And currently, he is the chairman of Liver Foundation of Thailand for the purpose of education to the people. Internationally, he was the Secretary General to the Apostle from 1978 to 1980, chaired scientific meeting during the Apostle in 1984, and Secretary General of the Asia Pacific Association for Gastroenterology from 1992 to 1996. The biggest event was to be the president of the Asia Pacific Digestive Disease Week in 2002, and also the chairman of World Congress of Gastroenterology held in Bangkok in 2002. This is the logo of the meeting, and this is the stamp, commemorative stamps done during the meeting. This is myself inside in the middle of the stamp. Moreover, the ASEAN perspective in liver disease was initiated by Professor Chainuvati. This is the cover of the first editions of the ASEAN perspective in liver disease held in Bangkok in 1997. Someone will wonder what is the second and the third. The second held in conjunction with the World Congress, and the third was held in conjunction with single topic in hepatitis B in 2007, held in Pattaya, headed by Professor Chutima Pamunsinsap. So what we have done to our liver society is enormous. So that's why we have named lecture for the society. So every year we will invite guest speaker to liberate the lecture to us as honor to Professor Chainuvati. And this year, we have invited Professor Leon Adams. Professor Adams is Associate Professor in School of Medicine and Pharmacology, University of Western Australia, and consultant hepatologist in liver transplant unit at Sir Charles Garnier Hospital. His research area is about non-alcoholic fatty liver disease. And he has contributed and published more than 80 peer-reviewed papers, and also had led many investigator-initiated studies related to the field of fatty liver disease. So today, Professor Adams will give us a talk on the topic of pharmacologic management of NASH. So please welcome and join us, Professor Adams, please.
Good morning. It really is an honour to be invited to present this inaugural lecture, and I can also please extend my congratulations to the organising committee to develop what I think is a very exciting program and to locate it in this beautiful and historic region. So this is the outline of my talk this morning. We'll be talking about the current treatment paradigm for non-alcoholic fatty liver disease, and then to understand the new paradigms that are flowing through, we need to understand a little bit about the pathogenesis. Then I'm going to be focusing on some of the emerging treatments of which new data has come out just in the last 12 months. And no talk is replete without mentioning the microbiome. So the current standard of care for treatment of NAFLD is lifestyle changes with the objective of inducing weight loss. So this is the current paradigm, if you will. And so do we need to progress from this? Well, clearly everyone in this audience would know that we do. And so this data is to just illustrate that point. This study came from Cuba. It's the largest series of patients that have undergone intervention with lifestyle change and lost weight, who have then subsequently gone under liver biopsy. And the duration of the study was 12 months. And you can see that if you lost 10% or more of your body weight, that almost all patients had resolution of their NASH, and nearly half actually had regression of their fibrosis. So a very impressive therapeutic response. The problem with this is that less than a third of patients were actually able to lose significant amounts of weight. And so 2/3 of patients, it had no effect. We also know that sustaining or maintaining weight loss is difficult. And this is some data from the Look Ahead trial, where in this particular sub-study, 1,000 patients were followed over an 8-year period. And despite having a quite intense intervention, the amount of sustained body weight at 8 years was only 4%, which was actually probably not enough to sustain these histological changes. So new treatment is clearly needed. In terms of pharmacotherapy, what do we have currently available? We have vitamin E and pioglitazone based on some soft recommendations from the liver associations, and this is mainly stems from the PIVNS trial, where vitamin E and pioglitazone, when compared to placebo, were demonstrated to have a significant reduction in the proportion of NASH. However, note that it's still less than 50% of patients had a therapeutic response to this treatment over a 2-year period. And furthermore, in this study, patients who had diabetes or who were cirrhotic were excluded, and these are probably our patients at greatest risk of morbidity and therefore our patients at greatest risk of need. Furthermore, there is some concerns about tolerability and toxicity with these agents. Although vitamin E is thought to be fairly innocuous, there are some large meta-analyses which have suggested it may have been associated with increased risk of mortality or hemorrhagic stroke, heart failure and prostate cancer. Pioglitazone has well-acknowledged side effects of weight gain and fluid retention and has earned a black box warning from the FDA for heart failure. So there's limitations to these current treatments. So if we're going to think about new paradigms of treatment, we need to understand a little bit about the current pathogenesis. And this is a simplified schema outlining that. So we do know that dietary excess, dietary fat, leads to weight gain, and in association with a likely genetic predisposition plus or minus influences from the gut microbiome, this will lead to weight gain, which preferentially in patients with NAF seems to go to the visceral subcompartment. This visceral fat is pro-inflammatory, insulin resistant, and highly lipolytic. This leads to altered glucose and lipid metabolism accumulating in hepatic fat. Then toxins, be they lipids or intestinal toxins, can precipitate liver injury, then stress in the endoplasmic reticulum as well as the mitochondria, accumulating in cell death, activation of hepatic stellate cells, and fibrosis. The current drug treatments can be thought to be either attacking the abnormalities of lipid or glucose metabolism, such as pioglitazone, or targeting the so-called secondary hits in liver injury, inflammation, and fibrosis, which we have with vitamin E, and there is some evidence for pentoxifylline as well. So there's not many on this list. But if we look at drugs which have failed treatments, there are actually quite a few more. And why is this? Why are we having difficulty finding successful drug agents in NASH? Well, we've come to realise that there are multiple pathogenic pathways involved in the genesis of both hepatic steatosis and liver injury and fatty liver disease, and that these pathways have redundancies, so that if you target one pathway, a subsequent or parallel pathway may well take over and lead to liver injury. We're understanding that the NAFLD is a heterogeneous condition and that treatments may be more effective in certain subtypes. When we look at in the lab, our disease models for fatty liver disease are imperfect. They rely on genetic mutations or dietary deficiencies and therefore do not replicate fully the human phenotype of NAFLD. And lastly, when we try to translate our lab findings into the clinical trials, we know that fatty liver is a slowly progressive disease, and so large numbers of patients over a long period of time are required, which makes the practicalities of these trials difficult. And lastly, the trial endpoints are uncertain. Should we be looking for an improvement in NASH or fibrosis, and what actually defines NASH? So this has all led to difficulties in drug treatment. There are, however, a lot of emerging treatments on the horizon, and this is just listing some of them. And again, they can be classed basically on those that attack the insulin and lipid metabolism abnormalities, or those that are going into liver injury or inflammatory pathways. Now, these list are only the drugs that are either finished phase 2 or currently undergoing phase 2 trials. And there's a whole separate long list of potential agents that are being investigated in early phase 1 trials. So for the purposes of this talk, I'll be concentrating on these 3 agents, which have got the most data on them to date. So pioglitazone is a PPAR gamma agonist. However, there are 2 more isoforms of the PPAR receptor, the alpha and the delta, and they have effects on lipid and glucose metabolism. PPAR alpha increases fatty acid oxidation within the liver, but also has anti-inflammatory properties, whereas PPAR delta is thought to be the fat buster agent. It increases fatty acid oxidation within the muscle as well as in the adipose tissue. And so a drug which combines these 2 targets would be an appealing proposition for fatty liver disease. And indeed, there is a drug, elafibranor, or also previously called GFT505. I'm not going to go through the animal data which supports this drug, but this was a phase 2 trial, which was an international multi-centre trial, which was recently presented at last year's ASL. And it was a 1-year trial of 274 patients with paired liver biopsies. They had a fairly modest inclusion criteria in that you required a score of 1 for steatosis, ballooning, inflammation, meaning that your total NAS score could be a total of 3. It was there was 2 doses of elafibranor that were tested, the 80 milligram and the 120 milligram. The lower dose, the 80 milligram, didn't have efficacy, and so the data presented concentrated on the higher dose. And this is a summary of their histological findings. After a year of elafibranor, there was a significant improvement in the number of patients that had resolution of steatosis, ballooning, and they're the combined endpoint of NASH, or NASH if you limited it to patients with a baseline NAS score of 4 or more. But you can see that the absolute efficacy was relatively mild, with only 19% of their patients having NASH resolution throughout the trial. Due to its effects on adipose and skeletal muscle, however, there were additional cardiometabolic effects. There was a significant reduction in the elafibranor treated groups compared to placebo in serum triglyceride and cholesterol, and an improvement in HDL, as well as an improvement in HbA1c levels. Now, this is important given that the number 1 cause of death in our NASH patients is not actually liver disease, but it's cardiovascular disease. So any drug which is treating both their cardiovascular risk profile and the liver disease is beneficial. The second agent that I'm going to be talking about is a GLP-1 analogue called liraglutide. And this has been approved for treatment of diabetes and at the higher dose treatment for obesity. And the treatment for obesity stems partly due to its central effect on the brain to reduce appetite and also cause gastric paresis. This particular mechanistic study, which was recently published, tried to look at its effects independent of weight gain on weight loss on the liver and the adipose tissue. And by using insulin clamps and isotope tracer studies, they demonstrated that liraglutide was able to improve hepatic insulin sensitivity. It reduced fat production by the liver and also reduced hepatic glucose output, thereby lowering blood glucose levels. In parallel to that, it had a strong effect on the peripheral adipose tissue by increasing its insulin sensitivity and therefore reducing the lipolysis and the rate of fatty acid spillover from the adipose to the liver. And all these things summed up to reduce the hepatic steatosis. So this agent, liraglutide, has subsequently been looked at in a paired biopsy phase 2 trial, which was again of 1 year's duration. It was relatively small in number, only 45 patients, and this is their baseline characteristics. Thing to note here, importantly, is that they did include patients with diabetes and those with advanced fibrosis. So this is the group that are probably hardest to treat. This is the take-home slide of their results, and liraglutide at the 1.8 milligram dose had a significantly more patients who resolved their steatosis, their ballooning, and also their NASH. The liraglutide did not improve fibrosis, but it did reduce the rate of progression compared to placebo. The known side effect of weight loss was seen in this trial, with patients having liraglutide losing about 5 kilos in weight. And this also corresponded to improvement in their cardiometabolic profile, then a reduction in their HbA1c, and improvement in their HDL cholesterol. Notably, however, the side effects of liraglutide, which are also well acknowledged, are predominantly gastrointestinal. In total, over 60% of patients had some sort of gastrointestinal upset, predominantly nausea and diarrhoea. And 8% of the subjects, compared to 4% of placebo, actually withdrew because of gastrointestinal side effects, perhaps limiting the tolerability and efficacy of this drug. Now, there is a higher dose of liraglutide which has subsequently been approved, and that's approved for weight loss of 3 milligrams, but there's no data currently in NASH for that drug, for that dose. Now, the third agent that I'm going to talk about is obeticholic acid, and it's an FXR or farnesoid X receptor agonist. FXR is a receptor which is expressed in the intestine and also the liver, the adipose tissue, so sites which are important in the pathogenesis of NAFLD. And one of its main jobs is to regulate bile acid, but it's also been demonstrated to impact on lipid and glucose metabolism. And so obeticholic acid is a semi-synthetic bile acid, which is a potent FXR receptor. It's been examined in the Flint trial, which was published in The Lancet in 2014. And again, this was a large trial of nearly 300 individuals over a 72-week period. Cirrhotics were excluded at baseline, however, patients with diabetes were included if they were well controlled and not on insulin. And again, obeticholic acid had a histological effect with a reduction in their NAS score and also a reduction in their fibrosis score, perhaps the most important endpoint in these trials. Interestingly though, in terms of their NASH endpoint, it didn't quite reach statistical significance, and therefore was concluded was that it didn't actually reach their primary endpoint. Furthermore, additional problems with this drug are its side effect profile. Nearly a quarter of patients experienced some pruritus, and a number of patients had to withdraw from the trial because of this. And also it increased LDL and reduced HDL, so it may have a deleterious effect on lipid profile. So if we summarise these recently published phase 2 trials, the obeticholic acid and the allofibranor are attractive given their oral route of administration, whereas liraglutide requires a subcutaneous injection. They all had modest effects on NASH resolution, and although liraglutide had the highest amount, these aren't quite comparable given that their definitions of NASH resolution were slightly different. Fibrosis resolution has been demonstrated with obeticholic acid, but its problems is it doesn't have a favourable cardiovascular effect and has problems with pruritus, whereas liraglutide has gastrointestinal toxicity. So promising agents, but are they going to be the answer in the in the longer term? I don't think so. Another phase 2 trial that's been recently published has been Armacol, and this comes from Israel. This is a synthetic lipid conjugate of cholic acid and arachidic acid, and its job is to inhibit the SCID1 enzyme. And the effect of that is it basically reduces fat within the liver by reducing its synthesis and increasing its oxidation. It has an added beneficial effect of promoting cholesterol efflux, which may be important in atherosclerosis. This trial confirmed its efficacy in reducing hepatic steatosis, so this was measured by magnetic resonance spectroscopy at the higher dose of Armacol compared to placebo. This trial did not do biopsies, and so we don't really know its effect on liver injury or fibrosis. So of the drugs that I've focused on thus far have all concentrated on attacking that lipid and insulin glucose pathway, whereas there are a number of drugs that are being investigated looking at liver injury and fibrosis. And these include antifibrotics, which are not necessarily specific to fatty liver disease, but have been trialled in fatty liver disease given the need in this population. There's anti-inflammatory drugs which affect target the immune cells within NASH, and also drugs which are targeting apoptotic pathways in fatty liver disease. The first of these I'm going to mention is Sinacrivirac. It's an anti-inflammatory drug which was originally used in HIV because it inhibited HIV viral entry into the cell, but it's also a chemokine. It attracts or exacerbates inflammation. And there's currently a phase 2b study that's underway in NASH. Of the antifibrotics that I mentioned, they are inhibiting the cross-linking of collagen or binding to glycoproteins to inhibit fibrosis progression and perhaps encourage fibrosis resolution. Now, interestingly, both of these drugs have been trialled in the very end stages of fatty liver disease, so those patients with cirrhosis or those patients with advanced cirrhosis, and these are long-term trials. The caveat to these drugs are that they require infusion either weekly or fortnightly, which will clearly inhibit their long-term utility. So lastly, to talk a little bit about the microbiome. So the knowledge that the microbiome may impact on liver injury in NASH was really introduced by this study published a couple of years ago. And what these investigators did in a mouse model of fatty liver disease, that's the MCD diet, they promoted dysbiosis of the gut, that is a change in the composition and abundance of the gut bacteria by a genetic model of inflammasome knockouts. And they co-housed those mice who had gut dysbiosis with wild-type mouse, knowing that mice are coprophagic, that is, that they eat each other's faeces, and so the microbiome from one mouse will be passed on to the microbiome of another mouse. And then after inducing a fatty liver disease, they compared their liver injury and liver histology, and you can see that the mice that had gut dysbiosis induced had a worse liver injury, And when the investigators gave antibiotics to restore that or knock out the gut, the liver injury was attenuated. So this is a proof of principle demonstrating that the gut microbiome may play an important role in the genesis of liver injury in NASH. But how might it do that? Well, it may promote hepatic steatosis by actually allowing you to absorb more nutrients. Gut bacteria can metabolize non-absorbable starches into absorbable short-chain fatty acids and increase the energy harvest for a given quantity of food. They may reduce choline metabolism, which is important in triglyceride secretion from the liver. Bacteria may produce endotoxinemia, and has also been implicated in altering gut hormone expression of this agent called FIAF, but also bile salts, as we mentioned before. They may promote liver injury by promoting the gut permeability and thus the translocation of injurious bacterial products or gut metabolites. And so what's the actual human data to support these hypotheses? Well, there isn't a lot available. This again was a mechanistic or proof of principle type trial where small numbers of healthy but overweight men had their gut microbiome altered, and this was either by antibiotics or by fecal transplant from a lean donor or their own faeces. These heat maps just demonstrate that the intervention worked to alter the gut microbiome in these volunteers, and then they underwent insulin clamp studies pre and post, and you can see that the intervention and the absence of any weight change was actually associated with alterations in their peripheral insulin sensitivity. So I guess providing evidence that the gut microbiome may well have an effect on insulin sensitivity, but the effect of these studies, actually the absolute magnitude of effect on insulin sensitivity is small. How do we put this in the paradigm of fatty liver disease? Well, there's been quite a number of small trials which have examined prebiotics or probiotics in the setting of fatty liver disease, and the predominant formulations that have been used have used Streptococcus thermophilus as well as bacteria of bifidobacteria and lactobacillus. The trials have been relatively short in duration, and there's been a whole mix of outcomes in terms of effect on ALT or steatosis. There's really been no confirmatory or strongly positive trials, and so I think the take-home message from this slide is that probiotics or prebiotics cannot currently be recommended as a therapeutic strategy in fatty liver disease. But I think this just illustrates our lack of knowledge of the microbiome. We know that animal models and that proof of principle human studies that there is an effect. It's just a matter of working out what the mechanisms are and how to harness those mechanisms. So with these new drug treatments that are coming online, there are going to be more questions that we need to answer. There are a lot of people out there with fatty liver disease. Which ones are we going to treat? We can't treat all of them with drugs because that would be an incredible cost. Should we be treating those with just NASH or just fibrosis, given that there is data suggesting that fibrosis rather than NASH is more of a prognostic indicator? Does treatment need to be personalised? We mentioned that NASH is a heterogeneous disease. Do we need to have different treatment pathways for patients who have diabetes, or different treatments for children versus adults? And is there a genetic differences which will alter treatment response? How do we monitor these patients when we give them treatment? We can't be doing biopsies serially, and we know that liver enzymes are poor surrogates for liver fibrosis, and so clearly more work needs to be done on non-invasive markers. We have questions about the durability of efficacy. We've seen with the PPAR gamma agonists that their effect tends to tailor off the longer that you're on it, and so our current studies are predominantly short-term. Lastly, there's always long-term concerns about safety, particularly malignancy and cardiovascular disease on anything that changes lipid and glucose metabolism. And lastly, cost effectiveness needs to be thought about. So in conclusion, there's no doubt that the primary treatment for fatty liver disease revolves around trying to lose weight. Although this is effective in only a small proportion of people, there's no doubt that it is cheap, cost-effective, and has additional benefits. The current agents that we have are vitamin E and pioglitazone, are also effective only in a minority of patients, but we've got two new drugs which are entering phase 3 trials, which may give us more treatment options in the future. I think the gut axis, the gut metabolic axis, or the gut liver axis remains an exciting field to interrogate, and the microbiome also offers some promise, but it's too early to look at now. And lastly, our patients at greatest need, those with advanced fibrosis and cirrhosis, there really is a limited amount of data in any of these treatments for this group. So I'll leave you with this slide. This is a sunrise in Perth, my hometown. And I was going to put a sunset, so I'd like to think that the sunset represents hepatitis C, that we're going to that we've seen the rise and establishment of effective drug regimens for hepatitis C, and we can hopefully now the sun is beginning to rise on effective drug treatments for fatty liver disease. So with that, I'd like to thank you for your attention.